Workshop on practical use of biologic therapy, and hopefully we will discuss some of the open questions you have concerning biologic therapy in psoriasis. I'm actually delighted to see so many people. I wasn't expecting more than 2 or 3, so thanks a lot in the beginning already for coming. As you know, we have made great progress in psoriasis, in our understanding of psoriasis, and this has led to a couple of new, more targeted therapies. And now we are able to treat inflammation, psoriatic inflammation, more specifically. The drugs which are available in Switzerland are the TNF blockers, adalimumab, etanercept, and infliximab, and the P40 blocker, ustekinumab. It's not always very easy in daily life to know which to use and how to use them properly. There are a whole bunch of guidelines, nearly a tsunami of guidelines. Some of them are like a holy Bible, as big as a holy Bible, actually. But in real life, sometimes they are helpful, sometimes not, because we have to take decisions with the patient very individually. So some of the questions we are very often asked when we get referrals from patients who should get treated with biologics are the following. People want to know which biologic should be chosen first, then how should we proceed in responders? Should we do a continuous therapy or interval therapy, intermittent therapy? What do we do if there is a lack of response, if the person is not responding in the first months of a primary non-responder, or if he loses efficacy during time, a secondary non-responder? And further questions are often how to deal with comorbidities. For example, if someone is obese or has psoriasis arthritis, or if he has latent infections like tuberculosis or hepatitis, or even cancer. And last but not least, quite important in often cases, how to deal with life events, like someone goes into surgery, someone needs to get vaccinated, someone wants to go on vacation, or wants to get pregnant. So Dr. Conrad and I want to do a workshop with you. We have prepared some slides and some cases which we want to discuss with you, but you can interrupt us anytime and ask us your questions. We want to do this as interactive as possible. First of all, one of the main questions we have is, what should be chosen first? And in the future, we'll probably have more genetic predictors, because we know that psoriasis is a genetic disease or has a genetic background. And some of the results which are already popping up are quite interesting. For example, if you are HLA-CV6 positive, you are more prone, or you have a better predisposition to react to ustekinumab. And there's also another work showing that if you have SNPs in this gene here, you're going to be a better responder to TNF antagonists. So this is coming up in the future, but for the time being, we have to deal with real life. And some of the factors which are important when we choose a biologic therapy are the following here. We have to see what type of psoriasis is it. Is it a very active, acute form of psoriasis, or is it a more chronic, stable psoriasis? How severe is the disease? What's the PASI score? What's the BSA? What's the DLQI? Then the comorbidities, as I mentioned before. Individual factors are really important. When I started as a resident, we just used to say, take this drug. In the meantime, we discuss with the patients, what do you think is optimal for you too? And then, of course, there are drug-related factors. Some drugs work quicker in the beginning. Some have a better long life. Some don't lose efficacy. Some lose efficacy more than others. And then, of course, some regulatory issues like infliximab has to be given second line. So let us start with a case. This is a patient, a 52-year-old woman with severe psoriasis, as you can see, a PASI 15, BSA 12, unresponsive to phototherapy, acitretin, and methotrexate. She also has a couple of comorbidities like arterial hypertension, positive hepatitis serology, and no psoriasis arthritis. That's actually quite important always to ask, does the patient have joint involvement or not? What's important in her social life is she travels a lot, kind of a jet set, likes to go around in the world. Actually, she's from the Philippines herself, and does trips practically every year. So what do you want to choose now in this case? Would you choose adalimumab, etanercept, infliximab, or ustekinumab? Who is for adalimumab? No one? I think it would be a good choice, actually. Etanercept, showing here, okay. Back there, someone from the company, I think. Okay. So actually, it's one of the TNF blockers usually we start off with. Although ustekinumab, there are some regulations, some guidelines like the ones from the British guidelines, though they are quite old now, which recommend to give ustekinumab as second line. In the meantime, it's catching up, I would say. We're getting more and more data, safety data from ustekinumab, so you could also consider something like this as first line in the beginning. But there are some factors which speak for etanercept in this scenario. It's a person who has some safety problems with hepatitis. She travels a lot, more prone to get tuberculosis if she goes around the world. So you're on the safer side if you're giving etanercept in this scenario. Has a short half-life. It doesn't lead to reactivation of tuberculosis in comparison to the other MABs. And you are more flexible in giving this. So you can do a continuous dosing if you want. You can also do an interval therapy if she travels around for a longer time. So in this scenario, etanercept is certainly a good choice. Here again, I put down some of the disadvantages in this case concerning the other drugs, like a higher safety concern concerning tuberculosis, for example. There's just much more data also concerning hepatitis with etanercept in comparison to the monoclonal antibodies. Especially with infliximab, we have a problem with the safety, with latent tuberculosis, and it's only approved for second line. So in this case, anyway, we couldn't give infliximab. We couldn't start with infliximab. As I mentioned before, ustekinumab would be also a choice, but we have less experience, and usually interval therapy is not recommended. Though, because we're giving it every 3 months, she could leave in the middle, actually. So I think ustekinumab is catching up there. What, yeah?
How often do you have to control the liver enzymes?
Every 3 months. If hepatitis serology, if you have enough antibodies, if the titer of your antibodies is high enough, you're usually well protected. But still, it's recommended that you control the transaminases every 3 months. Some people actually even check the viral load. It seems to be more safe with hepatitis C than with hepatitis B. Hepatitis B is actually a different problem. So as you can see here, etanercept worked very well with this patient. It takes a little longer usually, but after 6 months, a nice response. The patient stopped for 6 weeks where she traveled around, then she came back and we restarted therapy, just a couple of lesions here, and after 12 weeks actually, quite quick in this case, again, a good improvement. How does this story evolve then? Some people like to do intermittent therapy, but some people also like to do continuous therapy. And this is an advantage of etanercept. You can go for both. And indeed, in this case, after 12 months, you can see here nearly a PASI of 100 actually in this patient. And these are the people who then ask us, can we prolong therapy? And there are different opinions here, but some people say, you shouldn't, you just stick to the normal schedule. But in many of my cases, it goes quite well if you just prolong the intervals. And for example, in this case, we gave etanercept every 2 weeks. It's an off-label treatment, by the way, and it went quite well too. Okay, so then we continue with this case. She finally did, as I mentioned, a jet set. She wanted to travel around again and finally planned to go on a trip to South America. Now she has to get vaccinated. And there are different vaccinations that she has to get: typhoid fever, yellow fever, hepatitis A, rabies, and tetanus. And she's on etanercept, as I mentioned before, and she wants to know from you, what should she do now? Should she interrupt the therapy, or can she just go on with that etanercept every 2 weeks? So which vaccines are contraindicated during biologic therapy? What would you say? Killed vaccines, can you just give that to the patient and continue with biologic therapy?
Yes.
Would you agree? Okay. What about the live vaccines? No? Okay. Toxoid vaccines like tetanus? You can continue? That's fine. And none is suddenly wrong here. Huh? You're right. So you have to be careful with the live vaccines like yellow fever or oral typhoid in this case. And here are the other vaccines where you have to be careful. You should have them somewhere as a checklist. So it's yellow fever. The most cases I had in the last few years were yellow fever, actually. Sometimes typhoid, polio, measles, mumps, rubella, varicella, and BCG, all of them are not allowed during treatment of a biologic or with a biologic here. Non-live vaccines is not a problem. Now the next question that arises then, yeah?
Have you seen patients that got vaccinated nevertheless?
No, I haven't seen any so far, actually. I don't know what happened. It's just a risk, you know, if you really vaccinate them. But what would happen? There are some case reports with BCG that led to a sepsis afterwards. So I think you have to be on the safe side here. So what about the time interval? How long do you have to stop therapy now if someone gets a live vaccination? Is it 1 week? In this case with etanercept, is it 1 week? Is it 4 weeks or 12 weeks? Who's for 1 week? No one? Who's for 4 weeks? Quite a few. What about 3 months? So it depends on your mentality and perhaps also how good the patient is doing. Because if the patient has a PASI 100, nearly nothing, you can go maybe a little longer. You can be on the safe side. But actually, 1 year, 4 weeks would be enough. It's 5 times the half-life of etanercept, and that should be enough. But some publications actually, as the second 1 year, recommend that all TNF blockers should be stopped, be withheld for at least 3 months. Okay? Now, as I mentioned before, you can go according to the half-life, and you see etanercept has the shortest half-life, and that's an advantage of this drug in comparison to the others. And if you go for 5 half-lives, nearly 97% of the drug is cleared. So the shorter the half-life, if you have life events, is certainly an advantage. But we have to keep in mind that the half-life is one thing, and the other thing is the immunosuppression that a drug has, especially, for example, with Stelara, with ustekinumab. The immunosuppression can be longer, and that's why there are recommendations like the second 1 year again, which say that you should stay at least 12 weeks until sometimes even until 24 weeks. Again, this depends how the patient is doing. If he's doing very well, you could stay a little longer. I usually go for 3 months, just to be on the safe side. So, but with etanercept, you could go down to 4 weeks too. And then the other important point is you want the vaccination to work, so you can't restart immediately. Again, you have to wait again for about 2 to 4 weeks to restart the therapy. Okay, then I would like to pass over to my co-speaker.
So, after this nice presentation by Nikhil Yavalkar, we're going to go on to the next case. And again, a case with some particularities which guide you, which help you choose a biologic or another. So this is a 65-year-old male patient known for almost 50 years for psoriasis. He has possible psoriatic arthritis. History of dithranol, coal tar, phototherapy, methotrexate, which he did not tolerate very well. History of several squamous cell carcinomata, and a typical moderate to severe psoriasis patient with a PASI of 13.4 PSA of 12. So that's his clinical presentation. And as Professor Yavalkar said before, it's not your typical chronic, stable psoriasis. You have a patient which has smaller lesions which progress, and when you ask a patient, he said, well, the last few weeks it starts to aggravate, it got worse and worse, so you want something which acts rather fast instead of something which is slow, with a slow effect. So what would you take? Adalimumab, etanercept, infliximab, or Stelara? Who's for adalimumab? Why? Gets tough.
First one includes that.
Yeah? Other? Why not Stelara? Yeah, exactly. So it's not, you could use it. In my point of view, adalimumab is first line for me personally, and afterwards you could choose between etanercept or Stelara, which both would be fine. But as I said, it's not your first thing you have to worry about. It's a post-arthritis, so he does not have pain all the time. He has not a destructive disease, so he doesn't need an anti-TNF. But it's officially or clearly more effective than the others. Why not etanercept? it's a little less fast, less rapid in the onset. In the long run, it might be a very good option because you don't have antibodies against the drug, so you have less loss of efficacy in the long run, and patients tend to stay longer on the drug, so it would be an option for the long run. But here in this rather acute situation, you would rather go for adalimumab. And as I've said here, fast onset, very effective concerning psoriasis, very effective concerning arthritis. Remicade would meet all those criteria as well, but it's not a first-line anti-TNF, it's only a second-line anti-TNF, and as discussed, the others do not meet the criteria as good as adalimumab. So we put him on adalimumab, and 3 months later, he actually cleared almost all the lesions. The patient was very happy. We treated him for about 1 year and a half, and then he presented with that. Obviously, we cut it out. Diagnosis. Yeah, again, he already had a history of squamous cell carcinoma, so another one this time. We cut it out. What are you going to do? Do you stop the biologic therapy completely? Do you switch from adalimumab, which is an antibody, to the fusion protein etanercept? Do you switch the target from anti-TNF to anti-IL-12, anti-IL-23? Or do you just continue happily with anti-TNF? Anyone? And why? No one? Well, you can continue. Just continue happily. He has a higher risk of developing further squamous cell carcinoma. He already had some, but non-melanoma skin cancer is an exclusion. It's not a contradiction for biologic therapies, so you can cut them out and continue with the treatment. For all the other diseases, it would be a contradiction for a contraindication for biologic therapy. You don't have to stop it, you don't have to switch. There's no indication that etanercept would be any better. There's no data out there. Why do I have a question mark here? I'll get to that in a second. So this is data for adalimumab, 3,000 patients which were followed for about 4 to 5 years. And you can see that this is the rate of all malignancies, and there's no increase of risk for cancer in these patients. There's no accumulation of the risk during those 4 years. But this is the risk in general. So you see this is the relative risk for malignancies in the patient. So if it would be below the line, anti-TNF would be protective. If it's above the line, the risk would be higher to develop cancer. So overall in malignancies, there's no increased risk for those patients. But if you look for lymphoma, there's an increased risk in patients with rheumatoid arthritis. And for non-melanoma skin cancer, there's a significant increase for RA patients, psoriasis patients, and Crohn's disease patients. So they are at higher risk under anti-TNF treatment. So for adalimumab, there's overall rates for malignancies are the same as you would expect them from the general population. There's no increased risk, no accumulation of the risk for the patient in the long run. The incidence for lymphoma is higher in patients with RA, but RA patients are known for a higher rate of lymphomas in general. And more important for us, non-melanoma skin cancer, there's a small but significant increase in patients with RA, psoriasis, and Crohn's disease. For psoriasis, first, they have a lot of history of phototherapy, and psoriasis and Crohn's disease patients both are known to have a higher risk for non-melanoma skin cancer due to this continuous inflammation in the body. Does this apply for all other anti-TNFs? So far the data say yes, there's no difference between the different anti-TNF treatments or agents. This is data from the Danish registry, the biggest registry so far, and you can see that more or less the side effects are more or less the same, and there's no difference in the cancer or malignancies in general among these different agents. So there's no need to switch the agent in this patient. Now the question mark, why switching potentially to another target? And that's IL-12 and IL-23, which are both blocked by ustekinumab, have a role or play a role in tumor progression or tumor development. IL-12 mounts a protective immunity against the tumor, is therefore protective, while IL-23 is a pro-inflammatory cytokine, pro-immunogenic, and indirectly increases the proliferation of keratinocytes. So it's actually pro-tumor, so induces tumor growth or potentially induces tumor growth. So the question is, if you block both, what happens? And so far, we don't know. The data so far indicate there's no increase, no decrease in non-melanoma skin cancer in this patient in ustekinumab, but we will need more data, longer data, with more patients to see if there's a protective or an increase in non-melanoma skin cancers in this patient, and potentially also that a specific targeting of IL-23 might be protective for those patients. Christoph?
Is there any indication for specific carcinomas or malignancies that actually increase the incidence from the
No, so far not. They're all the same, yeah. They're all the same so far, but the data are less extensive than for adalimumab, which has the highest data collection or the biggest data collection so far. So the registry will tell us in about 3, 4, 5 years if there is a difference and if something is protective or not. We have one case in Geneva. Dr. Luffy presented it last year, who actually had, I think, basal cell carcinomas every 2-3 weeks to cut out. He was put onto ustekinumab, and for about 3 months, not one. So it's one case. You never make anything out of it, but at least there could be some idea that that targeting at least the IL-23 pathway might be protective. So I'll give you the other one.
Maybe another question. If I'm not mistaken, the incidence of melanoma is just 1 in 100,000 higher, I think, on the TNF than without, which is basically no different.
Yeah.
But nevertheless, this is a contraindication, if I'm not mistaken.
Yeah, for all other tumors, at least in the studies, it's 5 years. So when you are 5 years tumor-free for studies, you're free to put a patient on anti-TNF or ustekinumab. There's no real guidelines for that, but that's more or less what people do, let's put it that way. For melanoma, it's for me personally a little bit an exception. There's one study which has shown with only 17 patients, so there's no way it's significant, but they compared methotrexate to anti-TNF, and the relapse and second melanomas were clearly higher in the anti-TNF group. And therefore, since that was published, I'm really, really hesitant to give anti-TNF or biologics in general to patients who had a melanoma. But again, this is something for the registries and long-term safe data.
Great, okay. Can I go deep? Okay, so you're all waiting to see what's going on with this patient here, I guess. But it's a 58-year-old woman with severe psoriasis, as you can see, actually an erythrodermic flare, so it happened very quickly, this patient. Severe psoriasis, as you can see here, we hardly see these values. PASI 62, BSA nearly 95. Unresponsive previously to phototherapy, acitretin, methotrexate, cyclosporin, and she was actually on adalimumab when this happened. So she also has some comorbidities, as you can see, obesity, diabetes, no psoriasis arthritis again. That's again a very important question to ask when we want to put someone on a biologic or continued therapy. So what would you take here as the next option? Would you give etanercept, would you give infliximab, or would you give ustekinumab? Who would go for etanercept? No one? Okay, infliximab? Some? Ustekinumab? Okay, true. Yeah, it's kind of a choice between these two here. Right? Etanercept takes a longer time to come into action, so sometimes even 6 months and even longer. So in this scenario, it's certainly not the drug of choice. Infliximab and ustekinumab, you could give infliximab because it's second label in this scenario here. You already had adalimumab before. You could also consider ustekinumab because the patient doesn't have psoriasis arthritis. And ustekinumab works quite well too, quite quickly too actually. But in this case we decided to go for infliximab because in my opinion it's still the champion league here when treating psoriasis. It works very quickly, has good efficacy, and a lot of people even hold this efficacy, although there can be a loss of efficacy over time. So, but it has the quickest response, and in this case, where we have an erythrodermic psoriasis, I think it would be the best option. And the second important part here is it's body weight adapted. Ustekinumab is also body weight adapted. We have 2 doses there, but they're more or less fixed. So it's just over 100 kilo we would give ustekinumab, less than 100 kilo we would give 45 milligrams of ustekinumab. But here it's the only therapy we have so far which is really body weight adapted. And again, in obese patients, there are publications showing that patients who get such a body weight adapted therapy react better. As I'm showing here, etanercept is not really an option. We could give the double dose of etanercept, but that's really expensive, and I hardly do that. And so you could, for the first 3 months, it's actually labeled to give etanercept in twice 50 milligrams, but that's incredibly expensive. I don't do that usually. And as I mentioned here, although body weight adapted, still infliximab is, in my opinion, the better choice here. And luckily, this woman reacted quite well. You can see here, actually, in 10 weeks, she nearly didn't have anything. This is a picture of 12 weeks, and said she was on infliximab for ages, actually. You can see, I think she had really 2 or 3 years of infliximab without any problems, without having a single lesion. And then, suddenly, she developed this kind of rash. Looked like psoriasis, partly, looked like eczema on the other hand. So we had some kind of loss of efficacy here. It wasn't quite clear what it really was. Was it just a flare-up of her psoriasis? Or was it something else? Was it kind of a paradoxal psoriasis? And that's sometimes a tough question. But anyway, she had a loss of efficacy, and there are different possible reasons for a loss of efficacy. Maybe there are some new trigger factors, so always if something like this happens, ask the patient, did you take any new drugs? Did you have any stress events lately? Did you have any infections lately, which could be the reason why she has more active psoriasis at the time being. Sometimes we just don't find out why she has more active psoriasis, and just activity for a couple of months and then it calms down again. Sometimes it's a problem of compliance, not actually with infliximab, because this is an advantage of infliximab. People have to come in, get their drug and go out, but if they're on a subcutaneous therapy, maybe they're not using the therapy anymore if they're doing so well as this lady before. So sometimes it may be a problem of compliance. And then there are 2 interesting issues. Maybe it's a different clearance of the biologic, or the biologic is generating antibodies against the biologic, so anti-drug antibodies. Now this is not very common, but quite common with the monoclonal antibodies, and usually doesn't happen with etanercept. It's not so clear yet if it happens with ustekinumab. Probably also does happen, but it's not much data around there. But all biologics actually make antibodies, that's important to know, but with etanercept they're not neutralizing, with the monoclonal antibodies they are neutralizing. So we have the possibility at the moment to do a test in Lausanne, where we send some blood, and they give us the level of the drug, so the level of infliximab, the level of TNF, and if anti-drug antibodies are around. So we did this in this case, and what would you guess? Was it positive or negative? Who's for positive? Who's for negative? Actually did it twice in this patient. It was negative. I don't know why it was negative. I'm not sure about the sensitivity of the test. Maybe Corinne can tell us something about that because it's done in Lausanne. But we did it twice because I was quite sure this lady has positive anti-drug antibodies. But anyway, she didn't. What can you do in a scenario like this? You can add topicals, you can add another drug, you can try to optimize therapy, do a dose escalation, or you can change the biologics. Of course, we tried topicals, didn't really work so well. Methotrexate, not optimal for this patient. Acitretin, probably, she had it before, not optimal for this patient too. What we did is a dose escalation. But I just want to show you what kind of dose escalations we can do with the other drugs. So with adalimumab, you can do a reinduction, then increase the dose to 40 milligrams every week. With etanercept, as I mentioned, you could do 50 milligrams twice weekly, but it's only approved in the beginning. So these are all off-label recommendations. With infliximab, you can do a reinduction, or you can shorten the intervals to every 4 to 6 weeks. And with ustekinumab, you can increase the dose to 90 milligrams every 12 weeks. If that doesn't work, you can go to 8 weeks. Okay? So these are the possibilities you have with the different drugs. What we did in this case, we did a dose, actually I did a reinduction with her, and we shortened the doses to every 6 weeks, added topicals. Went quite well after a certain time, took quite long actually to get her under control, took more than half a year. So if you're trying a dose escalation, you have to give it some time. You can't just do it for 2-3 weeks and then say, oh, it's not working. Sometimes it will take months to get the patient back on track. But as you can see here, this stayed. For some reason, the palmoplantar psoriasis just remained, and we couldn't get that on track with the dose escalation. And then we had the idea to give another off-label therapy here, alitretinoin, and now with every 8 weeks and alitretinoin, she's again practically in a normal state again. So it took nearly 9 months, if I remember back with this patient, to get her back to the state she was before with this combination. She's doing quite well with this since about 3 months now. Okay, so I think we'll pass on to the next case.
A quick add-on to that one. Actually, the second part of the first patient, or a little bit different, but something that Professor Javalkar just said. Patient which is obviously very expensive, infliximab every 6 weeks or 8 weeks, and alitretinoin is at least the companies will be happy, but the insurance probably not so much. So there's is a female patient, 60-year-old, also for 50 years with psoriasis and palmoplantar pustular psoriasis, which I've seen can be resistant to conventional biologic therapy with possible psoriatic arthritis. Phototherapy methotrexate was put under Humira with a good clinical response. But exactly the same issue. She responded extremely well on the body, but the pustules on the soles and plants just remain. So what do you do? Well, we heard one option, alitretinoin. That's not on it, but what else? You continue biologic therapy. That we agree. You add PUVA, you add methotrexate, you add acid-retin, or low-dose steroids.
Acid-retin is quite good on pustules, LVCs, right?
Any other? Actually, all of them are possible. We did the same, exactly for the same reason. Acid-retin is known to be effective on pustular psoriasis, but you can add methotrexate, you can add Belnor-Puva. Personally, and I think you agree, it's not everyone's opinion in Switzerland, but I wouldn't add PUVA therapy or UVB therapy entire body for a patient for under anti-TNF or under ustekinumab, for the reason they're higher risk for non-melanoma skin cancer. That's another trigger, so I would avoid it. There are other centers in in Switzerland who actually do it. No issues so far, but personally, just my opinion, I wouldn't add it. Just on the hands and feet, there's not so much problem there. Non-melanoma skin cancer on the soles and on the plants are rather rare, therefore a valid option. Methotrexate, acid-retin, low-dose steroids, something I haven't tried yet, but several centers have started to give that at 2.5 milligrams with excellent response rates, and also for the rather long run, and then they temper down and stop again. But all of them are obvious options. We did acid-retin, as mentioned, and she responded really nicely. We had her on about 9 months and then could stop again, and she's actually still doing fine. So what's the clinical relevance of that? And we have a specialist here in the audience, obviously, in that field. So positron might have another inflammatory pathway because it's not reacting to anti-TNF. So it might be mediated by IL-1 beta or IL-36, another IL-1 family member. And what we've seen in our patient, actually, we took some biopsies from acute paradoxical psoriasis and a side effect of anti-TNF, which is mediated by interferon, the type 1 interferon. TNF was absent in the pustular psoriasis, also type 1 interferon, but IL-1 was upregulated. So this is an indication that it might be mediated by IL-1 or at least IL-1 family, and maybe in the future we'll have also biologics which target IL-1 available. Obviously, they're on the market, but not available for pustular psoriasis. But maybe in the future we have an option, or maybe even a drug targeting IL-36. So with that, I'll go on to the actual second case. So this is a 56-year-old woman. You all know which drug you're gonna take. Psoriasis since about 16 years, probable psoriatic arthritis. Phototherapy was contraindicated, I'll get to that. She had for 7 years methotrexate with a cumulative dose of more than 8 grams, so rather a lot. PASI of 23.8, and that was her clinical presentation. So classical plaque psoriasis, stable, certainly not acute, so you might want something which helps her rather quickly, because she's suffering, but also something for the long run. So the feet or the legs, so what do you give? Cyclosporin, Humira, Enbrel, Remicade, Stelara. And why? Anyone for cyclosporin? As I've said, she's stable. It would be an option for a short run, so it's not a solution for the long run. It's a similar patient like the first one. Maybe you're not really aiming at really fast. So you could use etanercept or adalimumab. Infliximab is not indicated because she's not a second-line anti-TNF. And ustekinumab, she has an arthritis, so not the best option. So probably adalimumab or etanercept as the optimal treatment. That was discussed. Problem: she has a lupus. History of lupus in 96. Actually, without systemic symptoms, was on Plaquenil and under durable remission so far. History of chronic alcohol abuse. What about now? And why? Any idea? Why? Yeah, exactly. So the anti-TNFs are more or less contraindicated. We go with Stelara, even though she has an arthritis. Why? TNF inhibitors have an immunological side effect, which is paradoxical psoriasis, which is induced by anti-TNF. They can aggravate a pre-existing lupus or induce lupus or lupus-like syndrome. So obviously something you wouldn't want to do. It's a class effect of all anti-TNF, no matter which anti-TNF you take. How is that possible? So normally TNF and interferon have like a yin-yang, which is in balance. So if you decrease the TNF, interferon can actually take over and aggravate or induce a lupus or also an acute paradoxical psoriasis. That's why you wouldn't want to take an anti-TNF in these patients, and why anti-TNFs are more or less contraindicated for lupus, even though for arthritis or in the sense of lupus actually does some good, but in general it's contraindicated. On the other hand, ustekinumab, there's no paradoxical psoriasis, no autoantibodies, and no lupus-like syndrome, so it's a safe bet in this patient. Problems tend to build up. So we did the classical screening for the patient, and she had transaminase which were elevated, gamma GT for 244. So differential ganosis was a viral hepatitis, autoimmune hepatitis, drug-induced, alcohol-induced hepatitis, or non-alcoholic fatty liver disease. We did a FibroScan in the liver biopsy. She actually had a liver cirrhosis. Methotrexate or alcohol-induced, all the others were excluded. So what are options now? You don't treat her? Go on. Yeah, there's no contraindication. You can go on. In the case of cirrhosis, you can go on with biologics, not just with ustekinumab, but also with the anti-TNFs. They're not eliminated via the liver. They're not hepatotoxic. You can actually use it. And we introduced it, and after 2 injections, so after 4 months, she almost cleared. I had a pulse about 90, and you can see there's like this post-inflammatory hyperpigmentation which was remaining, and she's now for 2 years on the drug and still very happy. So with that, we're actually done with these cases, and I hope it gives you an idea of what kind of hints, what kind of factors which the patients give you can actually lead you or guide you to the decision of a specific drug during the treatment, but also choosing at the beginning or adding a drug or also changing a drug. Are there any questions, comments?
Just 2 things. There are actually some interesting case reports showing that you can treat cutaneous lupus with
ustekinumab. So it's a nice choice here, actually. The second thing, we would always try acitretin first, and then alitretinoin, but in many cases, actually, which we have had in Bern, people didn't react with acitretin, and they reacted with alitretinoin. So we had some pustular psoriasis. We had about 7 cases which we published, and 4 of those 7 cases didn't react to acitretin, but they reacted to alitretinoin when they had pustular psoriasis. It's just because alitretinoin probably has more inflammatory effects than acitretin. But anyway, the first choice would be acitretin, sure.
In rheumatology, they sometimes give low-dose methotrexate to prevent degeneration of
I don't.
Well, one thing is they also tend to treat psoriatic patient, arthritis patient much longer with methotrexate than we do. The issue is probably it's a different population. Psoriasis patients are much higher risk to have liver problems and get liver toxicity with methotrexate. I don't add it actually, usually. I add it as in a patient where you have complete, or not a complete loss, but some loss of efficacy. Either you decrease the interval, you increase for some time, or you add methotrexate, which I sometimes do. Otherwise, on the long run, methotrexate, often these patients had methotrexate and are getting on a biologic because there was an issue with it. But
I usually don't add methotrexate to a biologic, except perhaps if it's a really high need patient. If it's a patient who's gone through all the biologics, and let's say the last option is infliximab, I want to be on the safe side, and then I would add infliximab and methotrexate from the beginning. Usually methotrexate in a low dose, around 7.5 to 10. But usually, my experience is similar. People don't want to get methotrexate anymore. They have taken it for years, or they're not tolerating it, and then you're saying, okay, we're going to change to a biologic, and you still have to take methotrexate. They usually say no. So I usually go for a monotherapy, especially with infliximab, perhaps combination in certain cases.
An add-on also, because I said like this last line, one option is also to not change too quickly if possible, because we have at the moment 4 at our disposal, 4 biologics. There's 1 or 2 coming next year, but nevertheless it's limited. We don't have like 10-ish like the rheumatologists. So one option is really to add something at the beginning, or decrease for some period of time the intervals, or increase the dosing to get over transient loss of efficacy, and then if it's not working, then actually switching to another drug. Again, Enbrel has an advantage that the patients tend to remain longer, but nevertheless also there some people get a loss of efficacy, and then once you have to switch. So, and if you run through all the drugs within a year, then after 12 months you're just out of luck. So that's why I'd rather stay on it if possible and try to tweak it a little bit.
Yeah, that was illustrated in that last patient. As I said, it took really 9 months to get on track again. So. Okay.
A question: what about the need to do a CAT scan on long-term methotrexate patients? Do we have to do that, or we used to do the pro-collagen 3 years ago? What is what do we do today?
Yeah, we usually do the pro-collagen 3 tests. I do it every 6 months usually every 6 months, I would say. And when I reach about 3 grams, I send the patient usually to the hepatologist, and they like to do a fibroscan in Bern then. The biopsy is practically not done anymore because of the fibroscan. So with this combination of doing the PNP3 and the fibroscan after a certain time, or if your PNP3 is increased twice in 3 months, then you should you should send it to a hepatologist also. But usually I don't do a fibroscan before 3 or 4 grams cumulative dose.
We were discussing this, I think, last year. That we do also about after 3 grams, we do the same. There are centers which do it just every year. They send them over. The issue is a little bit if you have patients like your infliximab patient, fibroscan is for nothing. They just don't see anything because she's that obese. Then it gets a little bit more difficult. But also procollagen before actually you start, and then continuously. We do also every 6 to every 12 months. London, for example, they've started to just abandon fibroscan completely. They just do procollagen every 3 months. So there's no real guideline out there, but you try to get as close to be on the safe side.
Patients who have already developed antibodies at a high risk to again develop.
Yeah. I mean, hypothesis, because again, we have this yin-yang, and we know the B cell are also activated by the interferon pathway, so it's most likely that the anti-TNFs are a little higher at risk to produce anti-drug antibodies, and ustekinumab and anti-IL-17 have lower rates of anti-drug antibodies. In the case of Enbrel, they're not neutralizing, there's no problem there, but for the antibodies, the anti-TNF antibodies, this might be a problem.
Once you have these anti-drug antibodies, it doesn't make much sense to add methotrexate then, because it's not going to suppress the B cells enough actually. Yeah, it's possible then that you're going to be on the safe side and say for the next, if you have to stay with the MAP, then you start with the combination, yeah.
You manage paradoxic or psoriatic reactions or eczematous reactions. I do this more often than I thought.
Coding specialty
really
actually.
We're working a lot on that, and actually almost 2 years ago we've established a flowchart how to treat those. And since we're working on a research as well, because we found out how actually with this anti-TNF and interferon actually this misbalance or disbalance actually induces it. We wanted to publish that first and then actually put out this flowchart. But personally, if it's a mild paradoxical psoriasis, you can actually continue with the treatment and add a topical, if needed, methotrexate or just your classical psoriasis treatment. If it's moderate to severe, I stop. Because I've seen too many bad things like hair loss, bad hair loss in about 15 to 20% of the patient, which then leads that they really don't want to take any anti-TNF anymore. So I'll stop, we treat that, and once it's gone, you can discuss it. And it depends on the indication. So if it's psoriasis, I'll switch. If it's psoriasis, we have another option. We can go to Stelara, then I'll put them on Stelara and continue. For Crohn's disease or ankylosing spondylitis, you don't have any other option at the moment. So you tend to go back to the anti-TNF if needed and discuss with the patient if it comes back to immediately come back again. And the risk that it reoccurs is about 50 to 80%, so it's rather high. But that's why I'll tend to switch if possible.
There's a nice recent paper in Crohn's disease showing that ustekinumab works well in these patients. And we have about 2 patients now in Bern seeing together with the gastroenterology, and we switched them to ustekinumab. Let's see how they work there. So it makes probably more sense to switch instead to wait too long. So.
You can also, if it's psoriatic arthritis and ustekinumab is not sufficient, you can add leflunomide or Rava, and then most of the time it works. But these things we play together with the rheumatologist. So I think, thank you very much. I hope you appreciated the talks, and go out and play with biologics. Have a nice evening.
Thank you.